The Alberta model. The term has gone contentious in the media due to the seemingly massive rift it's placed between certain harm reduction strategies like safer supply and recovery-oriented systems of care. But has it actually? Or are we all just getting lost in the flashy sound bites? Dr. Rob Tanguay practices addiction medicine and pain management. He works for Alberta Health Services and is the Chief Medical Officer of the Newly Institute. Simply put, he is at the heart of the shift in this conversation about trying to better serve people lost in substance use disorder. And he joined me on the podcast to share his opinions and expertise. But before we bring him in, what's up? My name's Dan, podcaster, keynote speaker, and advocate, and this is Hard Knocks Talks, your addictions podcast. If you're interested in fostering productive conversations about substance use in your community, organization, or event, reach out to me at daniel@hardknockstalks.com to learn more about our public speaking and live onstage podcast production opportunities. Now, on with my conversation with Dr. Rob Tanguay.
This is Hard Knocks Talks.
What's up, Rob? How are you?
I'm well. I'm excited to be here.
I've been following you on LinkedIn for some time, and I mean we've been chatting for over 2 years now, back and forth from time to time, and it seems as though lately the conversation around substance use policy in Canada is taking another really big shift. For the past number of years, it's sort of been like harm reduction, and that started to gain some traction. But it seems to be going the other way now. Can you shed some light onto why you think that is?
Well, I think in and of itself, harm reduction isn't enough. And in and of itself, treatment isn't enough. And in and of itself, look, it's you need all facets. You need a system. If you don't have a system, you just have a bunch of sound bites.
Mm-hmm. Mm-hmm. Has your opinion of... And let's talk specifically about safer supply, because I mean, like we said before the show, like harm reduction is definitely not a one thing that we can provide to someone to bring wellness into their life. So more specifically, your thoughts around safer supply. Now, when it first entered the stage a number of years ago and it made it to the mainstream conversation about substance use in Canada, how have your thoughts about that changed from then to now?
Yeah, it's a good question. I mean, I'm not sure they've changed all that much. I think initially, look, I try to always look at things from a lens of policy. And when we're thinking about policy, we're thinking about health policy for all people, which is hard because we easily get tied into my one patient in front of me. And a lot of providers struggle to see the forest from the trees because they've specialized on a specific vein on a leaf on a tree. Mm-hmm. And so when we step back and we start looking at the forest, we have to start asking ourselves, how does this policy make sense? So, good health policy would say we need on-demand access to first-line treatment for everyone. So when you go in and get help for cancer, you don't just get thrown into a clinical trial. You're started on first-line treatments, different chemotherapeutic regimes, lifestyle changes, all of this kind of stuff. Mm-hmm. And if things happen not to be working, then you would shift down into experimental treatment. And, the reality is safe supply is an experiment. Mm-hmm. When we saw it rolling out before we had access to first-line treatment, this basically goes against, good health policy. Mm. So that's how I look at it. I don't really care about, a lot of people get all upset about safe supply or not safe supply. I don't really care about that. Yeah. I think in a system where we have access to first line, second line, third line, then clinical trials at mass stages are definitely worthwhile.
Mm-hmm. So what do you see as, like a frontline service like you just mentioned? What does that look like to you? What have you seen the most success in? And did that include maintenance strategies, and some might even call safe supply a maintenance strategy?
Yeah, sure. So first of all, the the data in determining what first line treatment is for an opioid use disorder. We're not talking about addiction anymore. We're talking about a single diagnosis within a spectrum of substance use disorders. And still not as damaging to society as alcohol and nicotine and substances that are legal and somewhat regulated. So what we're talking about is a subset that happens to get a ton of media because it's affected so many of us. And it's affected myself, it's affected you, it's affected many, many people. And so that's where it gets the mainstream. Now, that isn't actually necessarily a bad thing for health policy, because for the first time we're seeing a decades of underfunding in addiction and in mental health services now starting to become the forefront. And that is, basically what we see in our society today is the consequence of decades of underfunding and undervaluation and stigma and discrimination and racism, and the outcomes of that by poor mental health and addiction funding. But coming back to safe supply and what do I want to see? We need access to opioid agonist therapy, right?
Yeah.
So
Yeah.
buprenorphine naloxone is level 1 evidence. It's been studied in randomized controlled trials over and over again. It is a first-line treatment. It prevents death to those who have opioid use disorder or are struggling with an addiction to opioids, period.
Yeah.
Under that is methadone, which is our gold standard. But why a gold standard being kind of second line? It's second line because it's harder to manage and to monitor and is more restrictive towards an individual trying to get help.
Liquid handcuffs.
And then you can go into third lines from there and below. But that's the first thing. If I can't, Dan, you are as knowledgeable as anyone. When the iron is hot, you got to strike.
Yeah.
When somebody wants help, it's got to be there. Like, it's got to be there, and it's got to be there now.
Yep.
And that shit don't exist in this country. And that is a problem. And so all of our resources should be into that.
Now, something sort of came to my mind when you were talking about funding, and I wonder because we're seeing some safe consumption sites around the country. There's Insight, and then we have Prairie Harm here in Saskatchewan. They are having to reduce their hours now for their drop-in and their consumption site. And I can't help but wonder, even when they did have the funding that they formerly had, I wonder if it was enough. Now, do you think that if a safe supply program and a safe consumption site was better funded and better resourced, that we may have seen different results than what we're seeing now?
Oh, probably. Yeah. So look, again, let's be very clear. In a system that takes care of its most vulnerable, it has all levels of care in that spectrum. And things like a supervised site for consumption of illicit drugs or toxic drugs or non-pharmaceutical grade drugs, which is my favorite terminology, is using either it's pharmacologically grade or it's not. So non-pharmacologically grade substances is a great access point to starting someone on the road to recovery. But it has to be intertwined into the healthcare system. Yeah. And you talk about, safer supply or safe supply or publicly funded addictive drugs, or I don't know. There's again a lot of terminology behind.
That's a new
this.
one.
Yeah, well, that's Ontario terminology. The answer, in my humble opinion, is that it works, especially if we put it inside of a supervised consumption service where it cannot leave. So you can come in, you have a physician or a nurse practitioner there who will prescribe hydromorphone or fentanyl or heroin or methadone or Suboxone or whatever molecule, who cares about the molecule, whatever is required to help stabilize that individual. And they can't leave with it. So this whole issue around diversion dissipates. And more importantly, they don't have to pay for it. So the kind of criminal element that can come with it, because let's face it, for me to use drugs, I must do something to get the money to pay for the drugs. If I'm working, that's great. If I'm not working and I'm living rough without a home, well, I'm going to do what I got to do to get drugs because I don't want to be sick. That's like pretty, common sense stuff. So if I don't have to go do those things because the drugs are prescribed internally, I don't believe many of those people will do those things. Yeah.
Well, and that's challenging because I mean there are some people that just simply do not want to live a different lifestyle, and I don't know what we're going to do with them, but there are a good number of people that I believe who are accessing these safe consumption sites anyways, where if a pharmaceutical grade substance was offered, that it probably would help them to manage better and stay safer. But you mentioned diversion, and that's definitely something I wanted to speak with you today on, because I noticed that you're posting a lot of articles on LinkedIn on that topic, and there have been some recent occurrences in BC where there is a expected diversion from their safer supply program, but it seems like you're quite convinced that a good amount of this diversion is coming from the Safer Supply program in BC. And I'm wondering where that influence in your thoughts is coming from, because you specialize in pain management as well.
Sure.
You see firsthand the amount of medication that goes out through those programs. Why are you?
I have.
Why are you touting? Why are you pointing your finger at Safer Supply?
So first of all, it's not pointing my finger. Well, I guess maybe it would be. Look, let's talk about how we got here in the first place. Okay. We got here from the overprescribing of opioids. Now, we've blamed that on Purdue, and Purdue has spent billions of dollars in lawsuits, not on their lawyers, in paying out because they've lost. Okay? So if anybody says diversion isn't real, then Purdue wouldn't have spent billions of dollars in lawsuits that they lost, because they knew that diversion was happening, right? Yeah. So now let's step it back one more piece. If, as a pain physician, I prescribe someone oxycodone, and that's someone who's struggling with pain, takes it as prescribed every day, we wouldn't have been in a opioid crisis, because they wouldn't have diverted, because they took it as prescribed every day. Yeah. We got here because much of the opioids that were prescribed were diverted and ended up on the streets. And a lot of people ended up dependent, hence moving into an opioid use disorder or an addiction to opioids. And that is how we got here. We got here because we prescribed lots, access became easy because much of it was diverted. And by much, I mean, it might have been 3% or 4% or 5%, probably not huge numbers, but on a huge global scale, that's big, right? Yeah. So if you expect, when we're prescribing this for an indicated health disorder that has evidence, that we then shift to prescribing it for something with no evidence that it would actually benefit that individual, we have to assume there's going to be diversion, even if it's 4%, 5%. Maybe it's higher, maybe it's lower, I don't know. But the problem is that the protocols, the practice, and this is probably why so many of my colleagues around the country are writing letters and so upset about safe supply. It's because the practice doesn't try to prevent the diversion. And now, again, I've chatted with many safe supply physicians, and those are some of the most rewarding conversations to have. These are passionate individuals that really want to do their best. that in most cases really know that some harm is coming, and they're trying to figure it out. I've also spoken to many, many doctors who used to do safe supply and stopped because they couldn't figure out how to reduce the harm or the risk of harm to the community. Yeah. And these are conversations we should be having, not at political levels, which is unfortunate, but at the healthcare level. And we shouldn't be hearing political sound bites like diversion doesn't happen. This is all from the pain side. There's no evidence that any of this is real. There's tons of evidence. There's decades of overprescribing and diversion that led us to being here in the first place. It's almost like we decided we don't like to learn from our past. Oh, I know, that's a human trait. Yeah, but to not learn from our past from yesterday, this isn't decades ago. This isn't centuries ago. This is in our time. And we're doing it again. Yeah. Look, I'm only talking about the Health Canada protocol with tablet hydromorphone 8 milligram tabs. That is what's being funded. I am not talking about compassionate clubs. I am not talking about many other kind of programs that are out there. I'm not talking about individuals who are getting a prescription along with their OAT. I'm not talking about any of that. There's so many different practices, and these aren't even practices. Some of them are just culture and communities. That has nothing to do with this. I am talking about healthcare dollars being spent on giving someone massive pill bottles of hydromorphone daily or weekly, where they take it and use it unwitnessed. I don't understand. And now if we want to get into pharmacology, I can't expect somebody who is using fentanyl every day, whether smoking or IV at high doses, to stabilize on hydromorphone. There's no data that it is in any way possible to do so. So we know it doesn't work. Like that's like me taking somebody who's on OxyContin for chronic pain and saying, nah, you don't get your OxyContin anymore. Here's some Tylenol 3. It's good enough. The codeine is fine. You're getting an opioid. Yeah. And actually there was a question just posted here in the chat by my friend Barb saying, is the diversion happening because the prescription isn't meeting the need of the person using drugs? Without question. Like, and this is the things that can easily drive a physician crazy. Yeah. This is pharmacology 101. This is the basics of medical school. This is the first thing that we learn. Yeah. And we're doing the opposite. We are ignoring the high levels of tolerance to a powerful and sometimes really muddy fentanyl analog of some sort, and believing that by giving him hydromorph, they'll be fine. Now, to be clear, in areas out east where there's very little fentanyl and a lot of hydromorph on the street, this is probably a great idea. Yeah. Like I have no problems with it because now we're replacing something with something that's pharmacologically stable. In fact, many people may be getting pharmacological hydromorph on the street, but now we're reducing the criminality and everything else. All the methadone literature that we had from decades ago is what we're doing. A lot of people like to point to Switzerland and talk about the HAT studies, the heroin-assisted therapy. We treated heroin with heroin, and it worked great. Well, no kidding. We're treating heroin with heroin. So hang on a second. Now let's unpack that for a second. What does it worked great mean? What is the benchmark for greatness in this situation? Stabilization, pharmacological stabilization. Okay. Then you got to wrap it around with the services, psychosocial services. Look, to me, the most basic, let's find some housing, income, identification cards. Like, there's a new program up in Edmonton for the encampments where when you walk into the clinic, they have ID, like going into a registry. They have the camera, they have the printing machine, they have everything. Yeah. So you walk in and you will get ID walking out, not filling out a form and waiting a few weeks and having to come back and signing off again. Maybe it shows up and maybe you're still alive and maybe this clinic's still here and maybe you still live on that street. Yeah.
Yeah. Oh, I can't imagine if statistics were gathered, and I don't know, maybe they are, but if there was statistics gathered around how many people have died because they saw that form and they gave up. And because, I mean, filling out a form, I mean, it sounds simple, but when it asks you for your social security number and your health card number and your driver's license number, and you don't have any of those things, that's like a 6 weeks process just to fill out one form. And I wonder how many people didn't make it through.
And you can't access any services until you fill out that form.
I know. That's what I'm saying.
Horrible. It's disgusting.
Yes.
It is, again, I'm avoidant with forms. I fortunately have a good accountant.
Yeah, me too.
Because I just hate it, man.
I know, I hate it.
I look at a form and think, especially like the tax forms.
Yeah.
Everybody's like, oh, you just put this in that line and this line. I'm like, I don't know lines. I don't know any of these things. I don't know what this is. And I need help filling it out. Now we're asking someone with none of this stuff, with none of the experience to do it, to sit there for 2 hours filling out a form. They have no idea what they're doing. 100% that creates hopelessness.
Yeah, absolutely.
The system doesn't care about me.
So what if, and that's what you walk away with. And never mind 2 hours. If you simply don't have the information to fill that form out, that is not a 2 hour process. Like I said before, that is like a 6 week process.
Sure. That's not even a process at all. That's I'm done.
Yeah, exactly. On the bridge.
To me, that is our ability to cherry pick people who really want it.
Yeah.
And they're going to work. And then of course, what you got to do after that is you got to call every week.
Call every day to keep your spot in line.
Yeah.
Like,
I think
actually,
come on.
Thinking back 2 years now, when you were on last time, I think we popped off about that too. I always like to use the analogy.
Did.
Yeah. I always like to use the analogy of calling the hospital and them saying, okay, you run around the block 3 times and then walk in the front door and then we'll put a cast on your broken leg.
Right. Prove to me it's broken.
Yeah, prove to me that you want it bad enough.
Yes. I don't know if it is broken. I don't know if you actually want help.
Yeah. So having said what you did about prescribing practices and what physicians are allowed to prescribe, what if they were allowed to prescribe pharmaceutical grade fentanyl or carfentanil or whatever it is that the person was using? Do you think that we would see a higher success rate?
Yes.
Yeah.
So we created legislation in Alberta for exactly that. We have 7 NTS clinics that prescribe pharmacological support in NTS. It stands for Narcotic Transition Service. So it's basically supervised safe supply.
Okay.
And you can get anything by legislated mandate. It includes fentanyl and heroin and hydromorphone and anything at all. But you can't take it home with you. You must do it under a supervised format, which of course led to a lot of people being upset and saying people can't come in like that and da-da-da. But that is what IOT was designed on, and nobody was upset when IOT rolled out. It's IOT with any molecule necessary to stabilize.
Yeah, and that's how methadone practices have been run for years. I mean, I stood in line tons of mornings, made some friends.
Yep.
But,
maybe not good ones sometimes.
Maybe not. I don't know. Who's to say? That was so long ago. But then I ended up...
But that practice, in my opinion...
Yeah.
There are many reasons that Safe Supply clinics showed up, and very passionate physicians wanted to do things better and wanted to create low barrier. And it was because of this. It was because of the lineups and because of all that. So the idea was easy access to support individuals who can't do all that. But the response back should be buprenorphine should not be difficult to access.
Yeah.
There should be no daily dispensing. You don't need to watch someone dissolve it under their tongue. We have an injectable format. You show up once a month. It's as free as possible. And it prevents you from dying. Now, usually when I'm presenting, I have a COI. So just to be very clear, because people say I'm in bed with everyone. So just to be very clear, I have been to a National Advisory Council once with Indivior where I did not accept pay. And at CSAM last year, which I think you were at. Or
2 years ago
I don't know,
I was.
one of the CSAM. Yeah, okay. I moderated a lunchtime talk on a PhD who was presenting data on who and who does not relapse on opioid agonist treatment or with opioid. So nothing to do with buprenorphine. So I just want to be very clear about that. I used to always talk about all the pharmaceutical companies in my COI that I've been engaged with, but that's because I run conferences. And Dan, you've been to conferences. All of the pharmaceutical groups are the ones that are involved in exhibitorship, which really sponsor the conference and allow a conference to occur. Yeah. And so I have always believed in full transparency. It actually bit me in the butt by being over transparent, but I don't accept money personally from really anyone. So.
So let's shift over to another thing that you like to talk about, and that is involuntary treatment or mandated treatment or compassionate intervention, sure, or whatever the word of the day is. Let's talk about the pros and cons about a strategy like this. Now, and I can see I've heard too many stories of jailhouse genesis to sit here and say that there's no place for coercion on our spectrum. Sure. I can't. I'm sorry if you I don't know what to tell you, but also I have grave concern about strategies like this rolling out. Like I can see massive street sweeps, and we can see this could turn up to be something that could be compared to another 60s scoop if this is not done properly. Now, I'm going to turn it over to you here, and why don't you tell us what you've learned and what you've seen as far as pros and cons go to involuntary treatment.
So let's just start with the most basic response. I agree with everything you just finished saying. To start with the first understanding, I work a lot with police officers. I sit on the Calgary Police Commission, on the Alberta Association of Police Governance as a director. I've worked in the Operational Stress Injury Program, which is a federal clinic treating RCMP officers, and the Newly is all designed on treating first responders and police officers. I've spent a lot of time with police. Who are human beings who became police officers to help protect and save people, no different than nurses and doctors and EMS people. And it's a thankless job at times. And invariably, so many of them have told me that they have been thanked by someone for arresting them because it was the first time that they had an opportunity at not using drugs, which really talks about how just disastrous our system is and how horrific our system is right now, that the only way that someone got help was to go to jail. Now, that doesn't mean I think that we should put people in jail to get help. That is not what I'm saying. I'm just saying, anecdotally, this is what people have said. Now, drug courts have been around a long time. And there is evidence that drug courts can really help a lot of people. Everyone, no, but there's no intervention in chronic complex illness, in a health disorder like addiction, which addiction is a health disorder, just like cancer and heart disease. There's no evidence that is 100%, no treatment or protocol or anything in any healthcare out there. So it is one tool. Okay, so backing up. What about it? So we published recently the largest review of mandated treatment or involuntary treatment or whatever you want to call it ever done. So Dan Werb and colleagues did one on 9 studies a few years ago, quite a few years ago. We did one on 42 studies with over 350,000 participants. What did we find? No difference. There was no difference between voluntary and involuntary treatment. Sometimes involuntary treatment was better. Sometimes voluntary treatment was better. Sometimes involuntary treatment didn't use any sort of evidence-based treatments and were really bad. Sometimes voluntary treatments didn't use any evidence-based treatment and were really bad. So the conclusion of the study was that we didn't have enough knowledge of whether or not we should have this or not have it, and we can't inform health policy. Now, our reviewers were really upset. One of them really wanted us. I want to know, based on this outcome, what we should say to policy. And the answer is, we don't have enough data to inform policy. I'm sorry. You can tell me the 350,000 who went through it. Now, if we start pulling it apart, and we can do a ton of ad hoc comparisons, what we find: 1, There are no studies comparing involuntary treatment to no treatment. Let me be clear about that. There are no studies comparing involuntary treatment to nothing. And right now, in most of Canada, treatment is nothing. So we don't know that. 2, most studies don't talk about what kind of treatment they offer. Most did not include psychiatric diagnoses, mental health supports, or mental health treatments. And most didn't actually even tell us what kind of treatment they provided. We don't know if they were on a cement floor in a jail or if they were in a high 5-star luxury hotel providing OAT and trauma-focused therapy and mental health supports. We have no idea. So that really is the flux that we sit in. The fear of rounding people up and forcing them in. I just, it's a catastrophic movement in the media. I would just say we don't have the infrastructure to round up anyone and put them into any sort of treatment. We're still working in Alberta that has put, literally hundreds of millions. I think we're in the billions of dollars into building a treatment programs. We still don't have full treatment on demand.
If what you say is true, and I have no reason to doubt that it is true, and you found that there was no discernible difference between voluntary and involuntary treatment, why do you suppose Alberta's pushing forward with such rigor towards this strategy?
Okay, there's a precedence of treatment in mental illness. So if you were suicidal and you decided you were going to go to a bridge and try to end your life, everyone and their dog would try to stop you. Yeah. EMS would be there, fire would be there, police would be there. People would be trying to talk you down themselves. Yeah. We would then bring you into hospital, and we may keep you there against your will, involuntarily, to make sure you're okay. And to make sure, you have depression, we're going to treat it. You have schizophrenia, we're going to treat it. You have bipolar, we're going to treat it. If that same person was to inject a lethal amount of non-pharmacological grade fentanyl, we would do nothing.
Well, we've shown
we would walk by them laying on the street and do nothing. If they came to emerge, we would say, this isn't something we can fix in hospital, and discharge them and do nothing. Mm-hmm. So tell me how that isn't stigma, how that isn't discrimination, and quite frankly, how that isn't pure racism, because nobody's been able to tell me that.
Yeah. Let's take a quick break here and read out today's sponsors, and we'll get right back into it. The Advancing Interprofessional Management of Substance Use Disorders in Saskatchewan program, or AIMS-SK, is offered through the College of Medicine at the University of Saskatchewan and is designed to deepen healthcare professionals' understanding of substance use to improve health outcomes for individuals with substance use disorders. This program consists of 3 modules, including the foundations of harm reduction in substance use disorder, opioid use disorder, and alcohol use disorder. If you are a healthcare professional in Saskatchewan and wish to reduce stigma and better serve those with substance use disorder, look for the AIMS-SK link in the description below. Fetal alcohol spectrum disorder, known as FASD, is a developmental disorder that can impact anyone. It affects the daily lives of over 4% of Canadians, but with support and services, individuals with FASD can thrive. Learn more at saskfasdnetwork.ca. If you're interested in fostering productive conversations about substance use in your community, organization, or event, reach out to me at daniel@hardknockstalks.com to learn more about our public speaking and live podcast production opportunities. If you're interested in checking out another great Canadian mental health podcaster, there's also a link to that show in the show notes below. To make contact or to learn more about today's sponsors, check out our new merch, or if you want to show some love and buy us a coffee, all of those links are also in the show notes below. So, what are we seeing internationally? Now, I know that you're doing a talk coming up at the Western Canada Addiction Forum. I hope to be there. I don't know if I'll make it or not. I'm doing my best.
Okay.
But
I hope you're there too.
Yeah, it would be great. But I am wondering, one of the talking points I saw in the description of your talk talked about seeing evidence from international from other places that have gone forward with involuntary treatment. Talk to us a little bit about what we're seeing abroad.
Sure. So let's start with how many other places do this. Australia, New Zealand. I think one of the things to remember is Massachusetts, the academic mecca of North America, has involuntary treatment. I was lucky enough to meet with some of the founders of the legislation in Massachusetts in putting together their involuntary program, and what we really focused on was what were the mistakes. And mistake number one was putting this into the criminal justice system. It can't be there. This is a health disorder. It has to stay in the health system. And they made that mistake. Mistake number two was the displacing of voluntary patients. So you can't do involuntary treatment without having access to voluntary treatment. Then that kind of makes sense, right? Like, you can't force someone into something he couldn't get to in the first place.
Yeah,
Like,
that's a great argument. And I've heard it said before, why do I need to cop a criminal record to get the help I need?
Yeah, right? Why do I have to go to jail to get the best help I've ever gotten?
Yeah.
So, and to be clear about that, this is a quick little plug, and I think BC is starting to look at this too. Alberta is transforming our provincial jails into therapeutic living units. So the Red Deer, Lethbridge, Fort Saskatchewan, Calgary's next, our provincial jails are now becoming therapeutic living units. Those are basically inpatient residential treatment centers.
That you have to be arrested to get into?
Well, you're in jail, and instead of being incarcerated, you now have a chance to be rehabilitated.
Okay.
And you live there. It's all day. It's group therapy. It's one-on-one. It's treatment. This isn't about being incarcerated anymore.
Okay.
And so it is a rapid transformation into what the prison system is. And how popular was it? The first 12 individuals, when they opened the spots, they said, look, anybody can apply for it who's currently incarcerated in a provincial jail, which is just over 400 people in Alberta. Over 200 people applied. So you told me some people don't want help. You know, during COVID, we had these kind of hotels and different things where basically people living without homes could be isolated if they tested positive for COVID. In there, most of them made sure there was access to pharmaceutical grade opioids and amphetamines and whatever somebody may be using so that they can stay in the hotel. They also decided, you know what, maybe we should have access to evidence-based treatments like buprenorphine and so forth. The vast majority of people chose treatment. People want help. They just don't know how. And the system isn't designed to make it easy for them, as we talked about earlier. So nobody chooses to live on the street in a tent in a harmful environment where there's gangs and there's human trafficking and there's just horrific stories. Nobody chooses this, but nobody knows how to get out of it.
Yeah. And I just watched a podcast with I believe the man's name is Jason Nixon. He was on the Jordan Peterson podcast. And, it was interesting to me to see this talk about what's going on in Alberta make it onto the Jordan Peterson podcast, and in a way I'm glad it did, because it a lot of what he was saying around the tent, the encampments and stuff, and like we're fighting so hard over these encampments and about what should be done with them, and people are getting so upset because they're simply being swept away. But to me it's there's horrific things happening, and it's not the encampments is a result of a deeper problem, and I don't even think housing is necessarily the root of this problem. So where do you think that's stemming from? Like, do you want to walk down that path?
Yeah. So first of all, shout out to Minister Nixon. Here's a guy whose father was homeless, who grew up with the Mustard, which is one of our street level housing programs, who then grew up raising money for the Mustard, who spent his whole life in the not-for-profit social service industry and is now a minister of housing. Like, I mean, what a cool story. He's also 6'8" and over 300 pounds, which is he's quite an intimidating dude to stand next to. But yeah, look, we see some of the data out of Edmonton where they decided enough. We create this new health center. This health center will connect everyone to housing, social services, addiction services, everything. And everybody, they would go in and break down the encampment and shift people. 8 warrants. That's all they arrested. 8 people. Hundreds were broken down. 8 people were arrested. So this wasn't a over police activity. Second to that, many of those people had homes. They were just in this environment because they don't know how to get out.
Yeah.
And now let's talk about housing. And I've said this many a times, and it was interesting at the conference. Minister Nixon said the same thing. Housing has 2 crises. One is the middle income individual affording a house. Yeah. In Canada, we don't have enough houses. That is one.
Let me just jump in here for a second.
Sure.
And talk a little bit, because I just bought a home. Like we're closing on it, and like I am. It's terrifying. It's exciting. It's all of the things, because I mean, we lost our family home all those years ago due to the actions of our addiction, basically.
Sure.
And I learned a lot from that, and I'm glad that I have that experience now. I wish I wouldn't have brought so much harm to the people around me, but anyways, that's a whole nother thing. But we are upwardly mobile people. Like Donna has a full-time position, and she is like management at a local nonprofit here in Saskatoon, and it's wonderful. And and I do this, and this has been very meaningful, and it's brought significant stability to our family through this work. And even with our combined income, it's like that's what it's going to take. Like a single parent working a minimum wage job, like they can't even afford a little apartment, let alone hope to ever owning something to call their own. So I just wanted to throw that in there, that it's a mountain to climb, man.
Yeah, it is. And I think it has nothing to do with people who are living on the street right now. Maybe a small fraction, right? Mm-hmm. There's always that horrible story of, somebody who is working, lost their job temporarily, rent went up, they couldn't afford it, they get evicted, they're trapped. Or, even worse is we've seen a few news stories lately of apartment buildings burning down and 24 people are displaced and there's nowhere to go. These horrific stories do exist. But for so many people living on the street, there are mental health concerns, physical health concerns, cognitive concerns, addiction concerns. It is such a multi-complex issue that simply saying we need to bring down the price of a condo isn't going to help that person.
It sounds to me, everything you just described there is the housing crisis as a result of a healthcare crisis.
It is a healthcare crisis. And a lot of these people have shelter and still are so unwell. And I got the opportunity to see it in a Housing First program that I worked in, where we were putting people in apartments all over the city. And then we go back to the apartment and the person was gone.
Yeah.
And we go downtown and we'd find the person. We'd be like, what are you doing? And they're like, you put me way in Southeast Calgary. I don't know anyone.
Yeah, I don't know what to do with that.
This is where my friends are. This is my community. You ripped me out and gave me nothing.
Yeah. A friend
so
of mine,
course they're not going to stay there.
My friend Rand Teed, a good friend of mine. You might know him, right? You know Rand?
I know Rand. We got to chat a little bit at the conference.
Yes. Yeah. He's been in the studio here. It's been great knowing him. And one of the things that he says that always stands out in my mind, and it comes to the forefront of conversations that I have, is you can't take away something without giving something. Like you can't take away the drugs, you can't take away the lifestyle, you can't take away all of that stuff unless you're ready to replace it with something. And it sounds to me like a Housing First program that is simply just that. Here's a house, far away from what you know is not the solution, because the person
No.
is left devoid of everything they know. And like, there's days that I mean, I'm 7 years in and there's still days I don't know what to do with myself, you know?
Right.
So,
It was Julian Summers that published the pivotal randomized control trial, multi-center housing first study. Now, housing first has become a political term to get money, so it's not what it used to be. But housing first was about intensive supportive housing with peers, and some interesting data comes out of those studies. One, when you put a big center of 100 individuals or more who are living rough on the street, and you put them into this, there was no difference in crime, no difference in drug use, no difference in anything. But when you put them into smaller centers where, there's accountability and there's peers and there's everything else, there was a dramatic drop. I think it was like 80% reduction in drug use and crime and everything. So we have to actually understand how to put it together. Now, what's fascinating in what he talks about is that, look, let's think about this for a second. If you got the choice, I'm going to put you in this building with 99 other individuals who are coming off the street, who are all using drugs and still involved in crime or whatever they're doing. Yeah. Or I'm going to put you over here with a bunch of people who are working and there's no drugs and it's a stable environment. What would you choose? No, I'm pretty sure we all choose the same thing. Why would someone living without a home choose something different?
Yeah.
Like stigma, discrimination, racism.
Yeah.
These individuals deserve stability and they need help with that. Now, let's not forget about 30% of people living without a home right now, unsheltered, have a moderate to severe brain injury.
Yeah.
You and I would require supports to stay in our home with a moderate to severe brain injury.
Yes, sir.
10% are living with schizophrenia that's untreated or untreatable. You and I would require significant supports to survive in our homes.
Yeah.
So we can't just throw these people in a shelter.
Something you said there sort of piqued something that I experienced, and it's a little bit different. But you said, why would people that are homeless choose anything different? Now, for me, when I was young and I was just getting into substances, I came into into my career. I started working in construction and manufacturing, and my first couple of jobs were just people that all smoked weed. Everybody smoked weed. That was normal. That's what I found was normal. And as I moved forward in my career and I leveled up and I started working in places where that was not the case, I found myself being pushed away from the workplace culture, because what I knew to be normal didn't jive with what everyone else was doing. So now I'm sitting in my car at lunch and I'm smoking weed and I'm doing all of these things, and I'm not having any extracurriculars with any of the people that I work with. And that just really deeply resonates with me with what you said, and is a perfect example as to what can happen when one person is displaced from everything they know and put somewhere completely different. Like if I was unhoused for 10 years and you came to me and said, I can get you a career, here's a suit, here's a tie, walk into that building, you're good, buddy. That's not productive.
Yeah.
So
no, this is the terminology of reintegration. We talk about Julian Summers said this the other day. We talk about deinstitutionalization all the time, but we don't talk about recommunicization, getting back into the community. What does it look like? What does it feel like? I think we like to call it reintegration. But we need that. We need to support individuals, and the best people to support individuals are people who've been there before.
Oh, peer support, hey?
Oh man, without question, peer support.
I think there's already some of that out there in some church basements and stuff.
Sure, yeah. They're all smoking and drinking coffee. But that I'm for, but I don't know if you've had Earl Thiessen on here before from Oxford House, but
it's been a while. But yeah, he was on.
Remarkable guy, and peer support housing, pre-treatment housing with peers, post-treatment housing with peers. I'm a huge fan of this model where you're supported, you're not alone. And, that we've all heard it. The opposite of addiction is connection. The opposite of addiction is hope. And if you have no hope, you got no shot. So the system has to provide you hope. Your peers got to show you that it's real, which helps you provide hope. And you got to have hope that you can get there, so that maybe I can wear that suit. Maybe I can do that job. But initially, there's no hope, man. There's no, the best hope that we're giving people is, here's a place to use your drugs. And we're trying to advocate for you to get better drugs.
Well, and I can understand it. I can understand that people don't want their loved ones to die, and in the system that we're faced with right now, like we've touched on several good points: lack of reintegration, lack of systems navigation assistance, lack of mental health supports, and like all of these things. I would say that those top three things are at the forefront, and we're just left sitting here being like, "Holy shit! I just don't want my son to die today,"
Good. So let's stop at that. So I because I'm a physician, I'm told all the time, you don't understand people with lived experience. My brother died a year ago, almost to this day, of an overdose by himself on the floor of a bathroom. Yeah. My best friend died about 2.5 years ago in COVID, where the funeral was like 14 of us, from an overdose by himself in his basement apartment after losing everything on the kitchen floor. My school best friend, like from grade 3 to grade 9, died of an overdose a couple years ago. I know from my brother, I know from my friend, I know from friend's family, from his kids. I know how addiction rips a life apart. I know what it's like to worry. Are they going to be okay? Are they going to be alive? I get all of that, not because I'm a doctor, because I've been there. I've lost. I've felt the pain. I've been to the funerals. I get it, right? I've watched my parents ripped apart. I get it. I understand it. But there's no evidence that prescribing a level of hydromorphone to someone is going to save their life. Yeah. There's no evidence that it keeps them alive. If there was, I'd be on the opposite side saying we have a randomized control trial showing these people do not die, and that it's equivalent to giving them buprenorphine. But when we want to look at the data and how we reduce the risk of death, the data clearly shows, a great study out of Boston, that if you combine medications for opioid use disorder, buprenorphine, naloxone, or methadone, with residential inpatient treatment where you get psychosocial supports, stability, 89% reduction of death. 89%. 9 out of 10 will live. Why are we not funding that? If this was cancer, we'd never have an argument about funding treatment. If this was heart disease, never have I heard, I don't know if we should fund antihypertensives.
Yeah, like a bunch of cheeseburger eating people. They did it to themselves.
Yes.
Never hear that. Well, you hear that on this show, but you don't hear it anywhere else.
Sure. How about lung cancer? All smoking. Yeah. We're funding every little last bit, even though with lung cancer, many are going to die. Yeah. But we don't stop treating. We don't provide hope to people. We have a bell at all the cancer clinics that they ring on their way out when they win. And we want everyone to know about that bell. We want to instill hope. Why can't we treat addiction the same way? We spent decades trying to educate people that addiction is a disorder of the brain. It is a disease. It is a mental illness. And now we have activists saying, no, people have a right to use drugs. It's a choice. It is their choice. Talk about destroying all the work against stigma. Because if it's a choice, pull up your boots and stop. If only it were that easy, I wouldn't have a job. It ain't that easy. Yeah. It is a chronic, complex illness, and some people aren't going to make it. But we should treat everyone with first-line treatments like recovery is the first and only answer, like any other health disorder.
Final thoughts? Anything you want to leave us with?
That was
pretty good. That was pretty good. All right, Rob. Okay, I'm going to turn you loose. Thanks so much for joining me today. You haven't heard the last of me. I know that you probably just do this once every couple years just to hope that I'll never call you again, but I'm never going to stop, buddy.
I appreciate what you do, Dan. I appreciate you bringing the voices of so many people who don't have a voice. And I'm really happy for you and your family. And, you know, I talk to patients all the time. You deserve a home like everyone else. You deserve that home, man. So congratulations, and really, really excited for you.
Awesome. Okay, Rob, we'll talk to you again. Take care. All right, if you got anything out of that, please hit that like button at the bottom of the screen. If you're not yet subscribed to us on YouTube, please click that subscribe button. We go live as much as we can. We got tons of content for you to catch up on. That's all I got for you today. Take care, everyone.
Say, this is Hard Knocks Talks.